So continuing in our session on global neuropsychiatry, I am very honored to introduce our next speaker, who doesn't really need much introduction, as he's one of the most eminent and influential psychiatrists in the country, Professor Dinesh Bhugra, who not only was president of the Royal College of Psychiatrists, but also of the World Psychiatric Association, or more recently, the BMA. He has published a large body of work. Much of it has been dedicated to the relationship between culture and psychiatry. So he's going to talk to us about this overall subject.
I have no idea who she was talking about. Wasn't me. Sorry, Gov. I'm really delighted to be here. Thanks very much for inviting me, and thank you all for being here. When I first arrived in this country in 1979, I had absolutely no idea what I was getting in for. Arriving on 31st of November, if you can believe that, no, 30th of November, at Heathrow at 3:30 in the afternoon. I came out of the immigration and it was pitch dark. Where have I landed? You know, you just think that, in India, you kind of sunlight, things happen. How do people stay awake till midnight? And that was my sort of culture shock. And then when I started training in psychiatry in Leicestershire, my clinical tutor in the sort of weekly supervision said, Dinesh, if you want to learn about British culture, you must watch Coronation Street. That was the only soap opera. I mean, there was Emmerdale and there was Blessed Crossroads, but we won't go into those. And I was quite struck by the fact that, how can a soap opera teach me about culture? So I started watching it because, my boss had told me that, and like a good Indian, you just do what your bosses tell you. I don't think I learned anything about British culture from Coronation Street. But what it did teach me was that the following morning, sitting in the old age psychiatry clinic, you could talk to patients and say, did you see Coronation Street last night? What happened? And similarly, when I was doing child psychiatry, then Top of the Pops was the thing to watch, because if you wanted to communicate. So that was my kind of introduction to cultural psychiatry. And two sort of case vignettes that I'm going to give you, and then I'm going to get into my talk. In 90s, let's kind of take a step back. I was still training, and I decided that I was going to do a psychosexual clinic. So I contacted the local psychologist who used to run the clinic in Leicester, which at that time had 23% of the population was South Asian. And one of the early couples that I was asked to see was referred from gynecology for inability to conceive. So, what are they doing in psychosexual clinic is a different story. So when in doubt, pass things on to psychiatrists to sort. So it's, this Punjabi man, Punjabi woman, and me. So the first question I said, what language do you want to sort of, Punjabi. So we started chatting and tried to get the history, tried to make sense of what they were coming, for. And the man kept insisting on speaking for the woman, wouldn't allow her to speak. Every question that I addressed to her, he would jump in. And for me, although you are used to, in the Indian context, if you're running an outpatient clinic, everybody except the patient will speak. And patient would be accompanied by 16 other patients. So question of confidentiality and privacy is very, very different. So in order to engage them, I brought the psychologist in, white, British, who spoke not a word of Punjabi. But having her in the clinic change the balance. And you were able to sort of do the work, and then it became very clear what the problem was and what needed to be done. Fast forward 10 years, and I'm sort of recruiting patients for my first research study looking at rates of schizophrenia in different ethnic minorities. Ealing Hospital, study starts on 1st of January. We're in 21st of January, and I haven't recruited a single patient. You kind of start panicking. How am I going to sort of finish this? And one day I sort of walk in, and the charge nurse is very excited. So, we've got a patient for you. I said, yay! So, I go and see this young lady. The story was that she was in her, mid-30s, had been married for about 10 years. And husband rang the community mental health team saying, my wife is mad. So the team went, did an assessment and said, no, there's nothing wrong with her, went back. Few weeks went by, husband rang again, and the community team went again, this time with a different psychiatrist and a different social worker. Same decision, no, there's nothing wrong with her. Husband got so exasperated that he kept ringing on a daily basis. You've got to do something about my wife. And eventually, they decided that they were going to bring her in for observation. And they said, oh, this is first admission. This is the kind of person you're looking for. Again, I sort of went in and said, okay, what language do you want to be interviewed in? And she said, she looked at me and said, do you speak Punjabi? I said, yep. So let's so the history, as I told you very briefly, and when I started interviewing her, within about 30 seconds, thought disorder just poured out in Punjabi. So when she was being assessed by white British English speakers, she was able to contain. They were making allowances for her thinking, and they were making allowances that her, English is her second language, so that's fine. So they were being politically correct. Husband was right, and she was suffering. So I think that was a sort of big lesson for me as to the role culture and language plays. And we know, cultural psychiatry is about cultural aspects of human behavior, mental health, psychopathology, and treatment. And we've already had two excellent examples from different parts of the world. It involves a number of disciplines. And I think after my Punjabi psychosexual clinic experience, I then decided to go off and do a master's in sociology and then a master's in social anthropology. I said, okay, I need to understand how to make sense of this. And of course, social psychiatry has its own issues, but when we look at culture, we can define it as totality of knowledge. It's about beliefs, it's about values, it's about customs which shape our behavior. It's about emotions and life patterns. But one of the big lessons as far as culture is concerned, there are two issues that we need to think about. One is in individual culture, and one is the group culture. And quite often there is a tension between those, but also what we need to bear in mind is that group culture can work in very different ways. So I can guarantee you that the culture in Queen Square neurology department is going to be very different from culture in neurology department in Birmingham or Leicester or Derby. One of the challenges for us as clinicians is how do we try and make sense of that? So it's common heritage, set of beliefs, norms, but it's about shared meanings. How do we make sense of that? And again, the interesting thing was that my tutor was an exception, that she asked me to look at British culture, because normal expectation is that only white psychiatrists need to know about black and ethnic minority cultures and non-white psychiatrists don't need to understand anything about white culture. So there is a tension there. And this is work done by Geert Hofstede, who's a sociologist from the Netherlands. Most of his work was done in large multinational companies, but a lot of these dimensions can be applied to cultures. So whether the cultures are sociocentric or egocentric, masculine or feminine, what the power distance the culture has from the center of power, how empowered do you feel as a member? And I think that goes back to the point that we were raising about poverty and brain, which is also about how much you can control and how much you're willing to accept. And some cultures are better at uncertainty avoidance and good at long-term orientation, whereas others are not. Egocentric cultures have very much personal focus, intimacy issues, authoritarianism, and independence. Sociocentric is about kinship. So one of the challenges for us as clinicians is that not every individual coming from a sociocentric culture is going to be sociocentric. And not everybody from an egocentric culture is going to be egocentric either. So there is that tension. And when cultures collide, and particularly as clinicians, we have our own cultural norms as doctors, where we've trained, where we are working, and patients have their own culture from the culture they've grown up in, brought up in, but also culture as a patient. So those expectations need to be matched. And we need to look at, in a clinical sense, what the role of the culture is. Does it predict behavior, why people do what they do? And we ought to be avoiding giving offense and search for commonality. Another classification of cultures is, again, sort of linear active culture, where in that particular culture, people do one thing at a time, concentrate on that, do it within a scheduled period. And again, I know this from the Indian context. Not interested in schedules, consider reality to be more important, do not like conversations unfinished. So you're doing 20 different things at the same time. But it's also, part of the process of my own acculturation in a way has been that, if things don't start on time, I get very restless, I get very itchy. And I remember going to a conference in Italy. I don't need to say any more, do I? 2.5 hours later, it hadn't started. And there were only 2 of us in the auditorium, 2 speakers, a German psychiatrist and me. And you can imagine what was going on there. So it is linear active cultures, Germany, vast Scandinavians, Austrians, Australasia, Japan, etc. And multi-active cultures, Czech Republic, North Italy, Chile, Russia, Portugal, Spanish, Indian, and parts of Latin America. And there are sort of, again, I don't want to spend a lot of time going into reactive cultures and proactive cultures, but there are, first message for you to remember is that we all have multiple cultural identities. And these are based on gender, sexual orientation, religion, and a whole host of other factors that we need to take into account. And in a similar way, patients come to us with multiple cultural identities too. So we need to make sure that when we deal with them, it's a practical response. And, by virtue of our training, we have our shared set of beliefs, norms, and values. And all professions have their own specific cultures, and it depends upon the jargon we use, the orientation, whether you have psychoanalytic interests or social psychiatry or biological psychiatry or neuropsychiatry. You've got a different worldview in that, and that becomes quite important. The second message for you to take home is that the cultures are dynamic. They change. We change in response to cultures, but we also change cultures. So it's a kind of ongoing phenomenon. It can change subtly over time, and people acquire cultures in a number of ways. But this is very, very important. The cultures influence our cognitive and social development. And that very much depends upon how children are brought up, who brings them up, what are the norms. And again, when I first arrived, it was such a shock to see that children had a fixed bedtime. You have to be in bed by 6 p.m. or whatever, or else. Whereas in India, children would be playing till 9 o'clock, 9:30, 10. When they are tired, just plonk them up onto bed, and that's it. Now, I'm not saying either is a right thing, but there are differences in terms of cognitive and social development, because that's how you develop your worldview. And the other point that we need to bear in mind is that the distinction between disease and illness, for us as doctors and clinicians, disease is literally dis-ease, which is about what we are trained to do, what we are trained to identify. We look at pathology, we say, well, okay, this is the diagnosis, this needs to be done. Patients suffer illnesses, which is that what's the impact of that disease on their social functioning. Most patients can live with their symptoms as long as they're able to function. People adjust, people can learn. Symptom elimination, we may be interested in. Patients are much more interested in symptom and social functioning. And we know that the society defines sickness. And again, 40 years ago, if you wanted to take a sick day off, you were allowed 24 hours, but after that you needed a letter from your general practitioner. And that then sort of somehow, somewhere along the line, allowed you to take 72 hours without a GP sick note. And I don't know what it is now, but I'm sure it's probably 2 weeks. This is a interesting model from Shu that this is the unconscious and pre-conscious, but from our point of view, these three layers, the outer world, wider society, and operative society and culture, are incredibly important because they impact upon our unconscious and our conscious and how we respond. People use idioms of distress to convey what's going on. These are very much culturally influenced. So if you have a Punjabi woman presenting with, "My heart is sinking," quite a common terminology. And and I know as well that if you don't, unless you have diaphragmatic hernia, your heart ain't going to go anywhere. And similarly, when somebody says, "I feel gutted," you know exactly what metaphor they're using, and those are very much culturally influenced. And it is that patients are interested in illness, and we are interested in disease, and that's the tension between patients and the doctors. We know that cultures affect generation of symptoms, expression of symptoms, how people experience and cope with symptoms, where they seek help from, and what the management of symptoms is. And again, one of my favorite stories about generation of symptoms is in the Indian subcontinent, you see a tremendous amount of semen loss anxiety among young men. And that leads to anxiety, it leads to depression, because it's seen as somehow by masturbating or having wet dreams, you're becoming weak and feeble. If you look back at history of psychiatry in the 19th century in America and in the UK, just at the time of when human body was being seen as machine, semen loss anxiety was incredibly common. And Kellogg invented cornflakes as a treatment for semen loss anxiety. So next time you have your breakfast, just think what you're doing. What that reflects is the impact that society has on creation of certain diseases, illnesses, experiences, and how people use them and how they manage them. And these idioms do not match diagnostic criteria. Patients never behave like their diagnoses. So the challenges for us as clinicians are that there is the category fallacy, that if we are imposing categories which have been of illness or assessment which have been developed in one particular culture onto others, we are in trouble. We know depression has different meanings. Many languages have no word for depression, and yet they would describe sadness, they would describe feeling tired, poor concentration, etc. But they would not use the word depression. And until 18th, 19th century, in this country, melancholia was used rather than depression. So it kind of, again, shows how diagnosis changes. And we need to bear in mind that one of the big challenges for global mental health is this notion that all human beings are alike. Yes and no. People experience distress in very different ways. People express it in very different ways, and they seek help elsewhere. So for psychological assessments, we may need to readjust the norms. We may need to look at conceptual equivalence rather than literal translation. And we may need to modify the tests. And certainly, there are different kinds of racism, and particularly in the clinical sense, institutional racism or missionary racism can be very dangerous. That I know what's good for you, you poor little thing, you cannot think for yourself. So we need to be very careful when we are creating the other bitches to do with how we keep micro-identities and so on and so forth. So racism can lead to misdiagnosis, underdiagnosis, overdiagnosis, and I've already touched upon the culture-bound syndromes. And one of the big challenges for us is psychopharmacology. And we know that in many cultures, people prefer injections because they are seen as more potent. Others prefer capsules. Some prefer syrup. Some like big tablets because they are assumed that there is much more medication and potency in that, whereas others like really small pills because they're much more concentrated. Some like red pills because they stimulate you. Some like green pills. So again, in clinical sense, we never sit down with our patients and try and explore if they've stopped taking their medication, why is it that they've done so, and what we ought to be doing for that. And we know, in the cognitive triad in depression, I feel horrible, the world is a dreadful place, and the future is bleak. And this depends upon I. Who am I? And if we go back to egocentric, sociocentric division, then definition of I would change. And there's been some argument in psychiatry and in anthropology that when we talk about deliberate self-harm, which self are we harming? Are we harming our social self or our egocentric self? And what does that mean in terms of therapeutic engagement, etc.? So the cognitions are responsible for explanatory models which are affected by culture, social, educational, and economic status. Cultures determine care pathways as to how patients come to us. And we know somatization is very common in some cultures because that's what the role of the doctor is. And if you do not have a distinction in your mind between mind-body dualism, Descartes' Cartesian philosophy, mind affects body, body affects mind, so you're more likely to present with somatic symptoms which are much more to do with, you may be feeling distressed, but your body's not working, or your joints are hurting, or something else is going on. And there are different kinds of somatization that we just need to medically unexplained, hypochondriacal worry, and exclusively somatic clinical presentations, but there is a degree of overlap. And I'm not going to go through these, but I just want us to look at the role cultures play, which is in the formation of symptoms, language and idiom which determine symptom expression, concerns of health and disease, and culturally sanctioned illness behavior that we need to be looking at. So we need to be sensitive in terms of assessment, what we need to do, how we assess people, their attitudes towards medical symptoms, investigations, etc. And I'm not going to go through treatment. If we have questions, then I can, cover some of that. We've touched upon pharmacological interventions, medication and its role. We must recognize that mind-body dualism is false, and we need to bring physical health and mental health much more closer together in training, in integration, and interconnectedness between brain and body. So I'm just going to sort of draw this to a conclusion in that culture has multiple meanings. It has multiple levels. It has multiple identities that we need to be thinking about, and we need to be understanding from the patient perspective. Patients will present in a number of ways, and their cognitions would well be influenced by their education, economic, social status. And we've already heard about sort of an impact poverty has. So, that was a kind of stunning finding that, children from poor families can only sort of, identify 1/3 of the numbers that people who are not poor, children from those backgrounds. So it's a much more challenging issue for us as clinicians, that we need to focus on the individual who's sitting in front of us to try and make sense of their experience and put that in the cultural context. Thank you again for inviting me, and thank you very much for being here, and thank you for listening.
Thank you for this wonderful overview. We have time for a few questions.
Thank you very much. That was a wonderful talk. My question is about language. And there is a theory that when people are bilingual, or when especially second generations, even if English is their first language, they speak differently still compared to native speakers. And the other question is, again, sometimes it feels that people can switch between two cultures or two personalities. They switch between two cultures or two personalities based on the language they speak. So when they speak English, they fit in the English culture and vice versa.
I think what we need to remember is that, depends upon when you learn your second language. Children are much better at picking up lots of languages, and if you learn another language later in life, then they're going to be sort of, you're much more rigid. One of the things that quite often I ask bilingual patients or trilingual patients is, to what language do you dream in? And to me, that sort of also reflects a sense of acculturation. Have you arrived at that level if you start dreaming in English? And of course, there are implications for the words you use to express distress, which would vary. And again, that depends upon your fluency and your educational status and socioeconomic status. So one of the challenges for us as clinicians is that, there have been 2 large-scale studies which have looked at ethnic matching of the clinician and the patient in terms of psychotherapies. Long-term outcome of psychotherapy makes no difference whether you have same ethnicity therapist or not. The only difference is initial engagement. So if we can change that, then language doesn't become an issue. I think everybody's ready for a break or something. Thank you.